Very honored to have this esteemed panel to join us today to talk a lot about strategic planning, and they're spending the whole day, most of the day with us, and wanted to take the opportunity while they were here in town for all of you to get a chance to hear from them and learn from their experience and learn a little bit about why they're here with us today. So I think we moved to sort of this room with the idea that it's kind of loud out there with the rain, so thanks for huddling in here with us. The room, sometimes it's hard with the camera for it to carry, so thank you for being on film. And also, thank you for speaking clearly so that it can be heard through the camera in this sort of big room as well. So I would love it if each of you would just take a minute to say your name and who you are and why you gave up a whole day and a half to come and travel woes and all kinds of things to come spend some time here with us at Livestrong. Dr. Shulman.
Good afternoon, everyone. My name is Larry Shulman. I'm a medical oncologist from the Dana-Farber Cancer Institute in Boston. And I have a lot of roles there. I'm still a practicing physician, mostly seeing breast cancer patients, though in the past I've seen patients with leukemia and lymphoma as well. I'm the Chief of Staff and the Senior Vice President for Medical Affairs, and I'm also the Director of their Global Cancer Medicine program. So I've evolved into a lot of different areas. I feel incredibly privileged, quite frankly, to be here, and I think I would start by thanking all of you for all that you do every day, for Livestrong, and for our community of cancer patients and cancer providers. And I don't make that statement lightly. I've been associated with Livestrong now for a long time. I'm not sure quite how long, maybe close to 10 years, and originally served on the steering committee for the network of Centers of Excellence for Cancer Survivorship, which Dana-Farber is privileged to be one of them. But I've also worked with Livestrong in a number of other areas, particularly health information technology and global cancer medicine. And we work together in Haiti, and the support that you've given us there has great implications for the work I also do in Rwanda, and I work in partnership with Paul Farmer and Partners in Health, and I think, as many of you know, Paul will be here early next week. I've been on email with him this morning. He's very much looking forward to coming and visiting with you again, I think in part to thank you for all that you do and for your support. So, you know, I think that Livestrong plays a critical role in the cancer world as a voice of the patients and helping providers like myself or national organizations like ASCO or the Commission on Cancer to understand the work that they do through the vision or the lens of the cancer patient and the cancer patient's families and loved ones, and has filled a tremendous void, first in survivorship, but now in, I think, a much broader aspect of cancer care. And without all that you do, we would be in a much less secure, less good place in the care of cancer patients. We have a lot of work still to do, and we'll talk a little bit about that, I think, as the hour goes on, about things that we might focus on in the coming years. But the work that you've done over the last 15 years has been quite remarkable. And for me, I'm privileged to be here for the day and a half I am.
So many of you know me. I'm Brandon Hayes-Ladden, and I'm also a medical oncologist. I take care of leukemia, and I'm a bone marrow transplant doctor in Portland, Oregon, where I also direct an adolescent and young adult cancer program. In part, I'm here because of my own personal story. I had cancer when I was 28 and connected to this organization when it was a testicular cancer organization, before literally anyone in this room was involved. That's true. You weren't employed. You were directly. I think you were the IT guy, right? I think, I have been so enthralled with the organization that I've weaseled my way closer and closer and closer to the point where I'm now your senior medical advisor, and extremely proud of the evolution that I've seen in what's really a short period of time, from seriously taking testicular cancer, which even as a medical professional at the time of my diagnosis, I knew nothing about, to now people understanding that testicular cancer is a thing. In fact, the most common cancer I could have gotten as a man my age. To then survivorship, which again, as you begin to describe what survivorship means, it intuitively makes sense, but it really was unknown and was undefined. And we've seen a complete transformation in what cancer survivorship means, led by this organization. I've been very involved in adolescent and young adult cancer issues broadly, which again is another topic which became a field, a whole discipline in oncology, spurred on by this organization. And so I remain really excited about how this group is able to listen to patients, understand the experience of cancer survivors, pull out what is often under-recognized, and both shine a light but also envision and create programs and services with partners to tackle those issues. There's lots of issues left, so there's lots of work to do, and I'm really excited to be here.
Well, I know many of you as well. I'm Barbara Jones, and I am on the faculty at the School of Social Work here at UT Austin. My travel this morning was pretty good. I live on the east side, so I just went the back route. But it wasn't hard to get here. But I'm a pediatric oncology social worker by trade and at heart, and so that's the pediatric, adolescent, and young adult group are the group that I really represent and think about most. I've been involved with the organization in a variety of capacities in the past 9 years, I think. Served on the steering committee with Dr. Schulman for the Livestrong Center of Excellence, have been on the adolescent young adult group, and most recently in evaluation of the emotional support navigation program. And every time I have an opportunity to be involved with the organization, either on a macro level or a micro level, I am continually inspired by the just unwavering dedication to patients and their families. And that's what I'm all about. And so I really don't know another organization, we've been talking about this morning, that responds so consistently, authentically, and nimbly to the needs of the community. And so that's an honor for me to be a part of every single time. So I am delighted to be with you here today, and look forward to what we keep working on.
I'm Melissa Hudson. I'm a pediatric oncologist, and I've been practicing at St. Jude for almost 24 years. And I actually have had, until recently, very limited need to interact with Livestrong because I have the luxury of practicing and the blessing of practicing in an operation where we really can fully see, to the needs, both medical and psychosocial, of our patients. And I initially did my practice, my active treatment practice was in leukemia and lymphoma, particularly in Hodgkin lymphoma. And over the last 6 years, I stopped taking active treatment patients because I had moved into survivorship, and we expanded our survivorship programs to include have our adult survivors of childhood cancer return to the institution for follow-up. And so since that time, I've become increasingly aware of more and more unmet needs in our young adult and older adult population, and struggled with how do you get these individuals to resources that we can so readily garner for our pediatric patients. And so we see that there's a struggle there. And so that's why I reconnected, and this has been a resource list of where you can find different things. This Livestrong was the resource that was typically at the top of the list there, and becoming more involved just recently with the advisory capacity with the Centers of Excellence. I began to learn more and more what the organization was doing and how important this work was beyond survivorship, with the navigation at diagnosis and continuing to see to both medical and psychosocial needs. So I think you are filling a big void in addressing the deficits in medical care and psychosocial care of the young adult and older adult population, and I congratulate you for that work, and I'm so happy that there's a resource there that's listening to patients and really trying to respond to their needs and hear really what firsthand is affecting them. So I think that you guys should be proud of the work you do, and you should recognize that it's making a big difference to the patients that you serve.
They're so eloquent. I worried that I might not be quite as eloquent as all of you. You're so well spoken. I'm Linda Squires, and I work at RTI International and have been working with Ruth and Stephanie on the cancer survivorship survey that you all do. And we recently fielded it, and now we're analyzing data from it, and we'll be analyzing data from the navigation study and also evaluating the out-school programs. We've got a number of new projects that we're very happy to be involved with. And we've just been working together for about a year, so I'm still very much learning about all the different programs that you have and continually impressed. I feel like I sort of weaseled my way into being part of your organization here. I know that I kept reaching out to Ruth and Stephanie once we started talking a little bit about the survey, and because I feel you're such an awesome organization, and I have directed many people to you. I can say both my parents have cancer. My mom's got non-Hodgkin's lymphoma right now. I mean, I've been touched by cancer in so many ways, and our neighbor 2 doors down was young. He was 23, and he died a year ago yesterday. So, but I did direct him to Livestrong before he died, and he was able to connect to so many resources that I felt so good about being able to do that, and connecting his parents as well, who were just totally blindsided by his diagnosis and how rapidly he declined. So, you know, being there, having resources available when people need them is so important, and that's really where I come in. My research and experience is more in cancer communication and getting people the information that they do need at the time that they need it, and you fill that role, and I'm very, very happy to be here to support your efforts.
Well, we thank you all for being here for that, too. I think you answered all 3 questions that I initially said I was going to answer. I have another question, though.
Very efficient.
Very efficient. So, you know, as a director of research, I sometimes feel like my colleagues may want to just say to me, why don't we just fund research? Why isn't that just what we do? Because so often that's what people think that we do. And they think we fund white lab coat, beakers, I think then we said one time steam. And so really that very typical research model. And I wondered if you all, who all do research, if you might talk to why the kind of research we do, or what you think about the answer to, should Livestrong have an open RFP that is in clinical research? Should we totally do something different than what we've done before, to go back to our original roots of funding research, and sort of what your thoughts are on that topic area?
You know, from my point of view, you have to decide what your mission is and where the need is. There are a lot of organizations that fund basic lab research, the NIH, the National Cancer Institute, the Komen Foundation, other organizations, and at the tune of billions of dollars every year. And we could always use more money, but that's an area that actually has a very good, solid structure to develop basic laboratory research to unfold the mysteries of cancer and develop better treatments. And likewise, there's a relatively robust mechanism to fund clinical research as well, trialing new drugs and so on and so forth. But there's been very little to support survivorship research. There are not good mechanisms through the National Cancer Institute. There's some, but not many. It's an underfunded area, it's an understudied area, and frankly, before you came along, it was an area that barely existed at all, and it was a huge need and huge vacuum, and I see you coming in and filling a vacuum that betters the lives of our patients. And so rather than trying to duplicate or add to something that's already well established and well taken care of, you've looked at what the patient's needs are that haven't been met, and have designed both supportive structures, whether it's resources or navigation, as well as things like the network of 7 survivorship cancer centers, where you've created a field that I think would not exist in the way that it does today without your not only your financial support, but your leadership in bringing the network leaders together 2 or 3 times a year. And not only funding their research, but challenging them to do the research that needs to be done for us to better deal with the patients. So, you know, your mission has always been the patient. And I think that's where your current activities are. And it's in an area that's a huge void without you being there. So I think you're in the perfect place. And the world changes, so we always have to think about what the best plan is for the next couple of years. But I think looking back, you've fallen right into the niche that you need to be in.
You know, we talked this morning a lot about what we think the strengths of Livestrong Foundation are, and you know, if you think about the reach and impact of less than 100 people in one building here compared to, you know, your peers in this space, it is unprecedented, and it's because of really smart decisions about how to use those funds, and funding the things that are going to really lead to transformation. Sometimes that is traditional research. Sometimes that is steering towards, you know, your underlying mission of listening to patients and being able to respond to those unique needs. And I think for, again, an organization that's not very old, the cycle of taking a critical look at what's funded is very fast. There's, you know, somebody said earlier, this is a very nimble organization because it's not that you necessarily would set up a funding mechanism in stone, but you I think at a fairly frequent interval iterate on exactly what it is you're funding and how that reflects the mission.
I think I would just add that there's lots of ways of knowing, and there's lots of evidence that counts. And one of the things that I think you all do very well is capture the voice of the patients. And so we talk a lot about patient-centered care. What I don't see a lot of is patient-centered research. And I think that when you are funding research efforts, it's geared towards how are we going to do a better job of providing emotional support navigation, or what are the distinct needs of adolescents and young adults in their own words. And that is missing. And so I think that's the place that you have settled in. I agree, you're where you need to be. And it fills a gap that doesn't exist.
So along the same lines, I think that as a clinician, there's nothing more compelling than interacting one-on-one with the patient or their family and having them verbalize their needs or issues, or seeing how the experience of cancer is impacting their lives. And that's also where you identify your research targets. And so you guys are poised to where, you know, in this changing healthcare system and reimbursement system and all the new challenges that we will have in the coming years, and having the voice of these survivors or newly diagnosed patients or wherever they are on the spectrum, you're going to be playing a very important role in identifying new research targets as those changes occur, and partnering with other organizations that, you know, may be able to implement those research investigations or you know, use you as a resource or collaborator in those investigations. So I agree. I think that you're filling a need, and this is an important unmet need in our survivorship group.
What they said.
You go first.
Yes.
No, I have something to add. Okay. I'm not a bench scientist. I'm a behavioral researcher, so I can't be more supportive of you being in the behavioral research space. And I think too that what Larry said is there's a lot of opportunity for bench research, and there's much less opportunity for doing behavioral research, and specifically doing behavioral research with survivors. So it's very important to stay in that space. And I guess the other thing is just we're your advocates as well. I mean, I'm very happy to be here, and I know that you all advocate for patients, but no, we advocate for you all too, and we're very honored to be here so we can try to keep you thriving.
Okay, well, does anyone in the room want to ask a question?
Yeah, I'll start over here.
Oh.
Actually, one of the top 3 issues the panel thinks are for cancer survivorship going forward.
I've got a few. I don't know if they're the top 3, but this might just be where I live because I'm also a behavioral scientist. Long term, how do I cope with this long term, right? The psychosocial aspects of living with cancer and living as a cancer survivor, and family caregivers, keeping families whole. Those are three that jump right to mind.
I think there's those same issues, but there's financial aspects of that as well, emotional and financial, particularly in our healthcare environment, and accessing those unmet needs, accessing care and resources to meet those unmet needs it's just critically important right now. We see so many people that struggle and don't have access to anything that can actually improve the quality of their survivorship, or don't even know where to start. And so I think that's a big challenge for us.
So I always, to come back to you, I always feel like, the top 3 or the top 5, is not a good way for me to think about things. Because sometimes it forces you to make choices that you shouldn't make. Not an either-or type of thing. Now, having said that, I think one of our goals today is to think about, what Live Strong should focus on. You can't do everything. You shouldn't do everything. And it's sometimes hard to sort of prioritize and decide what you're going to do and not. And as the group knows, because I mentioned this briefly, Dana-Farber just completed a year-long strategic planning process. And the hardest part of that was not deciding what we were going to do. The hardest part was deciding what we were not going to do. Because they were good ideas, people were invested in them. In the best of all possible worlds, they should all be done. But we can't do everything. We don't have the people, we don't have the funding to do everything. And so we had to decide what we were not going to do. I think you're going to do more than 3 things. And I think, if you reflect on what Melissa and Barbara were saying, we're complex organisms, us people, and, we're physiologic organisms with normal function and cancers growing in us. We're complex social organisms with family and friends and jobs and so on and so forth. And the focus that you put on in helping to improve the lot of patients who are affected by cancer is also a complex menu of things. We were talking about the Chinese menu concept where you're doing so many different things. That's because, they're all needs, and, whether it's financial or transportation or psychosocial support or physiologic support for, physical complications of cancer or managing your symptoms while you're going through treatment, and so on and so forth. All those things are critical. The problem with the way medicine has evolved over the last 100 years, and certainly the last 40 years that I've been doing it, is that that's almost entirely been from the view of the provider, the physician or the nurse. And there's been little input from the view of the patient or the family member. And in the case of cancer, when I started out, we had one focus, which was the cancer, and the patient wasn't always part of that focus in the way that they really should be. And it wasn't that I was a bad person, I don't think. But, that was what my training was, design a chemotherapy regimen and radiation and surgery to get rid of the cancer. That was our primary goal. And we didn't think much about what happened during the treatment or in the years after the treatment. Now we have a very different view, and I still have patients who were treated in the 1970s, who are suffering from the long-term complications of their disease and their treatment. And, you've helped us to look at that from the other side, and that's really a critical part. But it's not 3 things. It's a lot of things.
I might add, we did start our session this morning sort of talking about what we see as trends, though. So what is different? So again, this notion of focusing beyond just the cancer treatment itself. And there are, I think, emerging trends that this foundation is already active or at least keeping the pulse of. And broadly there are things around sort of personalization of both cancer biology, what's different between one lung cancer and another, to personalization, meaning what's the financial and psychosocial situation for each individual patient. So rather than sort of a cookie cutter approach to any service, whether it's the medical service or psychosocial service, how do we target those things? There's sort of a mirrored trend around the information and data that surrounds a patient and health information technology, and so integrating with electronic health records and these tools that are coming across as a trend in oncology. How do we apply what we know from patients towards those technologies? So I think that there are sort of macro trends that we're considering in advising our patients.
I wanted to ping a comment then off of Larry's comment. As you were speaking, I think one of our challenges is education. You guys are educating survivors or across their spectrum from diagnosis and beyond about where resources are and how to manage symptoms or how to access whatever their specific needs may be. It's also important for you to collaborate in the education of providers, because we have to get beyond this. The target is the cancer, and I think some patients either culturally won't ask about concerns or questions or side effects or whatever they're experiencing. They'll just want to have that time with their doctor to talk about what's happening with the cancer. And there's so much more that could happen if you took the time to say, what kind of side effects are you having? And, oh, I thought I was supposed to feel this way, so I wasn't going to mention it. So we need to be educated as providers, and so your collaboration and presenting the patient's voice and what we need to hear is important. So our educational efforts need to begin, when we're in medical school or sooner, understanding, the target is well beyond the cancer. It's keeping that person as well and having as good a quality of survival as possible.
My question is, you've spoken a little bit to some of this, but what do you see as the largest opportunity as well as the largest challenge for our organization moving forward?
So I think the largest opportunity really has to do with your position and relationship with patients, and listening to patients, understanding what's important in their story, and what things are broken and need to be fixed, and then leveraging that information both internally with your own programs, but also with your partners to how to fix what you're hearing from patients. I think that's a unique position.
And I would reinforce that. I mean, there are a couple of other things. You're a small organization, compared to the American Cancer Society or the American Society of Clinical Oncology or some of the other cancer-related organizations. And that gives you some benefits and some challenges. One of the benefits is that you're much more nimble than those organizations are. You can respond to needs in a much more rapid way than some of those organizations can. And you do respond from the voice or the view of the patient and the patient's family. Your challenge is, the David and Goliath thing. You're a small organization, and how are you going to leverage yourself to make the difference that you want to make, in a national or global sense, where you don't have, thousands of people working your organization and, the gazillion dollars that the American Cancer Society has, for instance. And I think you've done that very effectively over the last 15 years. But I think one of the challenges are to continue to figure out how to optimize partnerships with other organizations. You do that pretty well, whether it's ASCO or the Commission on Cancer or Partners in Health or, other organizations. But I think figuring out how to take your size and leverage into a bigger effect, if you will, is one of your challenges. And I think it can be done. But you have to think about it in those terms. You do a lot of good things. How do you scale that up to make a difference for a larger number of patients.
And I would add that I think you're a small, I've said this to some of you individually, I think you're a small organization that's seen as bigger than you are. And that's both a challenge and an opportunity. And so when we kind of did a bit of an environmental scan to ask folks about emotional support navigation, and Livestrong, people thought, other providers thought that basically there were this many people answering the phones. It was quite a few people answering, so you're seeing sometimes, because of the influence that you've had and the impact that you've had and the way that you've responded to needs in the community, I think sometimes externally people see you as larger than you are and then therefore put expectations on you in that. And so this dance that you have to do about scaling up and also being really clear PR-wise about, when I said to others, I'll tell you how many people are answering the phones, they were quite surprised, to find out. Is Hannah still in the room? And I began to worry, actually, about the people answering the phone. I'm like, they're going to start referring a lot of people. They need more phones. So there's this interesting position that you're in, and that has to do with the incredible impact that you've had. But that's sometimes a problem and a challenge, too.
I think one of your greatest opportunities right now at this point in time is rebranding. People are waiting for you all to come out after your saga this year, or last year, I guess. So being able to be really clear on your direction and then branding yourself towards the direction you want to be going in. It's really, it's unfortunate what has transpired, but it's also a really great opportunity for you to take a stance of where you want to be and get a brand that aligns with that.
And I would say I think you're already doing that, and you're doing it really well. I think your response has been quite admirable. And so I've been inspired by that too, to see how you've just been like, and we're still caring for people with cancer. Period.
And in the theme of, actions speak louder than words, your actions over the past years and your current actions now on behalf of cancer patients and the many, many ways that you benefit them and work with the rest of the cancer community is a huge statement for who you are and what your worth is. And, for me, it's more than anything you could ever say. It's what you're doing day in and day out and showing the cancer community. You shouldn't forget that.
So this has less to do with us, but what do you think is one of the most exciting things you see happening in cancer right now?
I just told you I didn't like that, sort of having to choose them.
What is something that you are personally thinking is something that's happening in cancer right now?
Seven things.
What is one of the things? It doesn't have to be anything we're involved in.
From my perspective as an oncologist, there are crazy great treatments coming out. I mean, things that are way more effective and way less toxic than we've ever had. And so that's hugely exciting. And that's going to influence all of the other aspects of what it means to be a cancer patient. That's going to change the answers you get when you're listening to patients, when you're asking about their experience. Their experience is going to be different. Sometimes in good ways, sometimes in really challenging ways. So maybe the survival rates are better, but the finances are tougher. It's going to change the dynamic a lot. But day to day in front of a patient to have a therapy for a disease that didn't have a therapy before is really cool.
And I'm much older than anybody else on the panel here. And actually, I became interested in cancer medicine in 1973, at the time that Nixon was declaring his war on cancer, and we were having our first successes in the treatment of Hodgkin's lymphoma and large cell lymphoma and testicular cancer and acute lymphoblastic leukemia. And it was a magical time. We were combining these drugs together, quite frankly, making it up as we went along and just trying this and trying that. But the outcome was some people were surviving who never had a chance to survive before that. And it was tremendous, but when you look back on it, we were basically taking groups of poisons where we had no idea how they were working or why they were working, and putting them together, getting lucky, if you will, in some cases, but also causing a fair amount of, harm to the normal tissues. And through the 80s and 90s, quite frankly, it was a very bad time in cancer medicine because we still had the same old drugs. We were juggling them around in different ways. We were not making much additional progress. And it's really the science over the last decade, our ability to understand on a molecular level what's happening in the cancer cell, that's led to drugs like imatinib or Gleevec or trastuzumab and Herceptin, which are so-called targeted therapies that are more effective than our standard drugs and much less toxic than our standard drugs. And we're already changing the face of cancer treatment, as Brandon was saying, and the face of the patients who are coming out the other end of treatment. So it is actually quite a remarkable time. The thing that we talked about earlier in the day, which you alluded to very gently, is that the finances of this don't make any sense from a sort of sustainable point of view. The cost of cancer care is going up so fast that as a nation we're not going to be able to support that in the current financial structure and how drugs are developed and how they're costed when they're released to the market. And we haven't done a great job as a country trying to figure that out prospectively and proactively. And so I worry that all the great advances that we're making are going to have such a dark side to them that we're going to be in a situation that will be, in the end, suboptimal for the patients.
I think it may be a little bit different for pediatrics, that we've had excellent cure rates for many, many years.
Well, you're much better than us, but yes, go ahead.
But
You are.
The challenges that we have with that is that, if we're now, it's over 80% achieve 5-year survival, and most are going to live long into adulthood. And our problems are we've manipulated these concoctions of these long available cytotoxic drugs, and now these newer agents are coming in, and how do you, if you have an established cure rate with a regimen that has been risk adapted and modified to make it as safe as possible, how do you take that leap? So we're struggling with the transition to those. In some cases where the prognosis is poor, it's very clear cut, and you move to those newer agents and you can integrate them quite rapidly. But we may have a slower learning curve just to be able to make that transition. I do think there's some incredible research ongoing, although I don't think it's really hit patient care in a broad way about the genetic factors controlling drug metabolism, chemotherapeutic agents, your risk for late treatment, acute and late treatment complications, how that may impact your treatment response. And I think that we're seeing it with our cancer treatments as well as with other aspects of medical care. We have a protocol running now where it's essentially personalized medicine. You get these genotypes, and then you'll get an alert in the electronic record. This patient shouldn't have codeine because they have this polymorphism, or this patient shouldn't have, you need to do something with their 6-mercaptopurine. So we are testing to see how that can be implemented in a clinical setting. And so we'll have that, but it may take a while before it's disseminated broadly. But that's quite exciting to know. Don't use that drug because we know that you're either going to hypermetabolize or not metabolize, and that's going to lead to a higher or lower risk of effectiveness or complications. So that's really exciting to me. And we often have this discussion when our survivors come back. They want to know what's changed, what's new, and we can share some of these challenges that we have as we're learning so much so rapidly. A lot of it's just related to the genetic factors associated with either the cancer or the individual.
In the behavioral realm, I would say I'm very excited that that survivorship and palliative care, to borrow a metaphor, have come out of the closet, and we can talk about them, really, and we can say that, palliative care doesn't mean you're dying. Palliative care means wellness and means, how do we make the best possible care for you and your family throughout, that we start at day one. What does being pain-free mean to you, or is that even your goal, or, who do you need around you, and all of that. I'm also I continue to be excited about what's happening for AYAs and with AYAs, particularly because I think right now the field, largely due in part to your work, is driven by AYAs. So they are driving the field, defining the field, demanding that folks talk about fertility and sexuality and relationships and all of the aspects of their lives that are really, really important. And it's not something we don't talk about anymore. And I think all of these are very exciting. So I think it's growing.
And to tag on to that, because I think it's well aligned, is now the emphasis on patient-reported outcomes, I think is a great opportunity and has been ignored for so long. So they have the PCORI funds now to move that along. So being able to give the patients the voice by saying what you care about matters, and we should be reporting on that too.
I will also say I'm excited about this. This happens more, I think it happens in pediatric cancer a lot, but it doesn't happen for AYAs, and this idea about patient-centered health homes and having your care be centralized continuously. So I think the more that we're making sure that happens throughout the age continuum, the better that is. I think in pediatrics, it has always, basically pediatric oncologists have been in charge, but for the adolescents, young adults, and older young adults, and older adults, it hasn't been so clear, so I think we're getting there. Other questions?
Before I get to Larry, how would you prefer, others have limited resources and time, why should an organization like ours be involved when those choices are hard ones to be given on the scale and the regionalistic part as well? Why us and why us forward?
So for those of you who don't know, maybe you'll find out more about this next week when Paul Farmer is here. I've worked with Paul for a number of years, and over the last several years have worked much harder, in part with your support and help, not only financially but in other ways, primarily in Haiti and Rwanda and Malawi. And you could ask the same question, from Dana-Farber's point of view, which is, why am I schlepping off to Rwanda like I was 2 weeks ago, and putting resources into cancer care in Rwanda, where, I could just be putting those resources into cancer care at Dana-Farber and the Harvard Medical School complex. And I think there are a number of reasons for us to do it and for you to do it. I think one of the hallmarks of Livestrong over the time that I've worked with you has been a demand, if you will, that cancer patients have access to quality cancer care. And that's not universally been true in this country, and it's certainly not universally true outside of this country. And I think in 2009, you held a summit in Dublin, Ireland, which I was fortunate to attend, where your organization put that on the table, and said, that we need to speak for the world's people, many of whom have no options for cancer care at all, have curable illnesses, potentially curable illnesses, but no opportunity to partake in the curative therapy. We're part of a global community. I think we have a humanitarian obligation to look outside of our backyard and try to make a difference to people who aren't so fortunate. Dana-Farber is one of the most resource-rich cancer centers in the world, as Oregon and St. Jude's and other places are. And yet, people a plane flight away have nothing. And for us to give our time and our resources to try to bring cancer care to people who have no other options, I think is a great privilege, and something I'm very, very excited and frankly honored to be part of at this stage in my career. We're providing cancer care in Haiti and Rwanda to people who have zero other options. There are no other places for them to get cancer care in those countries. And until we got there, if you had cancer, you died. It was as simple as that. It was 100 years ago in the U.S. You didn't get a biopsy, you didn't get treatment, you got put in the bed, and you lay in the bed until you died. And now you know, we don't cure everybody. We don't cure everybody at Dana-Farber. But we're curing lots of people and giving lots of people a chance for life who never had that chance before. And I bet you Paul will show you some examples of that next week when he's here. And, you know, so for me, it's been very, very important. And I will just add my personal anecdote, which you know I can't help but do this, is my son, who's a fourth-year medical student now, has gone to Africa 3 times and worked in our cancer program. He just came back a couple of weeks ago, having been in Rwanda for 2 months. And the younger generation, just like you know, who want to make a difference, the younger generation in medicine want to make a difference as well. And he's not, by any means, the only Harvard medical student who wants to or has gone over and helped us in this work. So, you know, it's our give back. You know, it's taking some of our resources from very rich environment that we have in the U.S. and sharing them in some small way. Now, we can't do that everywhere in the world, but we can do it in ways that, like you, can show the rest of the world how it can be done. And we're doing that. We're doing it, we're writing it up, we're publishing it, so that other groups can go in and try to do the same sorts of things in other areas of need.
You know, in reflecting on the question about, you know, how do you use your funds for what research means, you know, here's a perfect example where for relatively little funds you can have an enormous impact. Whether it's demonstrating that care can be delivered somewhere, or it's breaking down stigma barriers. You know, the ability to really leverage what a small group of people with a small amount of funds can do is remarkable. And it can be the spark that triggers ongoing change way beyond what you actually have your fingers on.
We're very, very grateful for your leadership and support in this area.